Hello everyone. It's exactly 12 p.m. So I'll go ahead and start. Dr. Chaput, are you there? Just want to make sure because your video
Yeah,
is
I
up.
am here.
Perfect. Okay, so we're good to go. So good afternoon, everyone, and welcome to today's webinar. My name is Siham El Mrayed, and I will be the moderator for this talk. Firstly, I would like to take this opportunity to acknowledge the traditional territories of the people of the Treaty 7 region in southern Alberta. The city of Calgary is also home to a Métis Nation of Alberta Region 3. And I would like to thank all of you for joining us today to listen and learn from our speaker, Dr. Katie Chaput, on the development and validation of the cannabis exposure in pregnancy tool. I'm very pleased to be introducing Dr. Chaput today, who's a perinatal epidemiologist and assistant professor in the departments of obstetrics and gynecology and community health sciences at the University of Calgary. She has also recently taken on the role of epidemiology rep on the CHS Graduate Education Committee. Her program of research is focused on mental health and substance use in and around pregnancy and associations with maternal and child health outcomes. She conducts quantitative and mixed methods research using primary data collection to inform policy, clinical practice, and public health. I will hand it over to you now, Dr. Chaput, and we will have some time for questions after the talk.
All right, thank you. All right, so thank you to everyone for joining today. I'm really pleased to be able to present this research today. I have no conflicts of interest to declare. So just a quick outline of what I'm going to go over today. I'll talk a little bit about substance use in pregnancy in general and why it's important. And then I'll get into the specific evidence around cannabis use in pregnancy, some of the limitations of the current evidence base, and then how that led us into conducting this tool development study. And I'll go through our methods and results with that study as well. So substance use in pregnancy is generally an important public health issue. And cannabis is an important part of that, especially in Canada now since legalization of cannabis in 2018. The fetal stage of development is incredibly sensitive to environmental stimuli and insults because it's the most rapid period of growth and development in the life course. So any external insults such as infection, drugs, nutrition, those kinds of things can have a really huge impact because there's just so much growth and development happening in short periods. We also know that many drug exposures in pregnancy are harmful to the developing fetus. Thalidomide, alcohol, tobacco are probably some of the most well-known, but there are certainly many others. And with cannabis specifically, there is a biological mechanism for cannabis to cause harm to a developing fetus. So we know that THC, which is the active, psychoactive component of cannabis, the component that makes the high feeling happen, can cross the placenta and it permeates fetal tissues. Humans also have an endocannabinoid system. And what this means is that there's cannabis metabolites bind to a specific cell receptor in human tissues. And the problem with that is that it can therefore block naturally occurring important molecules and hormones that are involved in growth and development. So when it's bound to those receptors, it can actually disrupt normal growth and development, including in neurological tissues. So there is the potential that cannabis consumption in pregnancy can be causing harm to a fetus as well. The costs associated with healthcare and supports for children with exposures to substance in utero are substantially higher than their unexposed peers. In fact, a report from before legalization of cannabis in Canada estimated that hospitalization for perinatal substance-related incidents alone costs Canadians over $147 million every year. And the perinatal period included in this goes from conception till about 6 weeks postpartum. So these costs wouldn't even include the long-term support and intervention needs for children that we know are actually much, much greater than those initial neonatal costs. Because pregnancy is such a sensitive period to potential harms, it's actually really difficult to study outcomes associated with prenatal substance use exposures, because obviously trials would be unethical. We can't really administer street drugs in a randomized controlled trial. So that means that we're really limited to observational studies, largely, especially when we're initially trying to figure out what potential risks might be associated with substance use exposures during prenatal period. So as perinatal health researchers, we really need to optimize the strength and quality of observational research for perinatal studies as much as we possibly can. So what is the current state of our observational evidence in the area of perinatal cannabis use in pregnancy? The bottom line is it's not great. So I'm going to break up the evidence base into sort of pre-legalization and post-legalization studies, and that's referring to the Canadian legalization in 2018. So pre-legalization studies, there were several that reported associations with low birth weight, preterm birth, neonatal intensive care unit admissions, maternal anemia, and suboptimal breastfeeding outcomes. However, there were also several studies that came out looking at the same outcomes and found no association with prenatal cannabis exposure. So the evidence is really moderate at best. A large systematic review conducted by the National Academies of Science, Engineering, and Medicine in the US, released just prior to legalization in Canada, concluded that we have moderate evidence for cannabis being associated with low birth weight or altered fetal growth, but there really is insufficient evidence to associate any of these other outcomes with prenatal cannabis exposure. And that includes neurodevelopment outcomes. However, it's important to consider in the quality of this evidence that the vast majority of these studies, and we're talking upwards of 80%, were conducted using data from only 3 cohort studies that ran from the 1970s to the late 1980s. There's one people may have heard of called the Ottawa cohort that was started in Canada in the 1970s. There was another one based out of Pittsburgh and another in Cleveland. So this is important to know because since the 1970s and 80s, there has been a drastic increase in the potency of cannabis products that are commonly available in North America. There's been a 250% increase in the THC content of dried cannabis products between 1993 and 2008. And a more recent study determined that the domestic cannabis products that are largely available on the market today have changed so much even in the last 5 years that they're genetically completely different from strains that have been approved for medical research by the National Health Institutes. So the average potency, just to put it in perspective, of THC in dried cannabis products in the 70s was around 3%. Today, the average of what's available on the general market is estimated to be closer to 24% THC for dried cannabis. More striking still is that for some vape products, and many vape products are even stronger than the dried cannabis, but 60 to 70% THC content is not uncommon. And then there also are high concentrated products like shatter and butter that are up to 99% THC. So huge increases in the types of products or the potency of products, there's also been a huge proliferation in increase in the types of products available. So this is includes candy, some of the other things that are on the screen here. And we've really never examined whether these different modes of consumption change anything with respect to the relationships that we see between prenatal exposures and outcomes. It's really important to consider all of this, though, because what we see in these pre-legalization studies really might not have any correspondence to what's actually happening in Canada today. And there may be a marked difference in the potential risks of prenatal cannabis use given the contemporary cannabis product market. Other limitations of the pre-legalization studies are important to note as well. There's very poor control for confounding in a lot of these studies. Many didn't control for confounding by things like alcohol, tobacco, or socioeconomic factors, or they had such small sample sizes and large overlap between multiple substance use in their exposed group that they were unable to assess for confounding because they didn't have power. They also often have very crude measurement of cannabis exposure in pregnancy. For example, some have a single yes/no question. One of the big cohorts only asked, how many joints did you smoke in your pregnancy, which could have missed other modes of consumption, although they were not as common back then. There still could be a substantial measurement bias in these studies because they would assume that all exposures are equal. And we know with our experience with other substances that it's very unlikely that someone who takes one puff of cannabis at one point in pregnancy is equally exposed as someone who has daily use or uses a single large amount during a party, for example. So there's a high risk of misclassification bias in these pre-legalization studies. So what about the post-legalization studies? Numerous studies have been published since 2018, including and specifically looking at perinatal outcomes and child health outcomes with exposure to prenatal cannabis. There are, this includes a few large studies from Canada. The findings of these studies also show some associations with things that were found in the older studies. So preterm birth, spontaneous preterm birth, premature rupture of membranes, stillbirth and fetal demise, placental abruption, small for gestational age, NICU admission, and low APGAR scores. And for those of you who aren't aware, APGAR scores are a general quick indicator of neonatal health that is conducted at 1 minute and 5 minutes after birth as a standard of care in North America and most of Europe. So we don't want to see low APGAR scores. That's an indication of trouble right after birth. One other study also included an outcome of abnormal developmental screening scores at 12 months and saw statistically significant associations there. So these more recent studies, and the Canadian ones included, all tend to use large administrative data sets for their data. One such data set, the important ones in Canada, one is the Birth Outcomes Registry Network, or the BORN network in Ontario, and the other is the Provincial Perinatal Data Registry in BC. The advantage of these studies is that they have very large sample sizes. So I think the smallest is around 150,000, and there's one US study that even has 12 million participants in it, or subjects. So obviously they have much higher power. They have much improved control for confounding variables, which is a real strength over the other studies. However, they still do have some really significant limitations that we need to keep in mind when we're assessing the quality of our evidence. The main one being that the way cannabis use in pregnancy is measured in these administrative data sets is through a voluntary self-report to physicians during routine prenatal care. So this is really problematic for a number of reasons. First of all, because it's not assessed. Cannabis use is not a standard assessment in prenatal practice in North America. A recent study also showed that cannabis is considered a very low priority issue among obstetric care providers. So it's not being asked much, and it certainly wouldn't being asked in a consistent way between patients. And so we don't have great standardization around that. Secondly, we have really strong evidence that pregnant women tend to conceal or underreport substance use in pregnancy. A recent US study showed that only 36% of women who screened positive for cannabis with urine toxicology had also reported their cannabis use to their doctors. So the misclassification bias remains a big issue in terms of cannabis exposure, even in these later studies. And just to put it into context, how big an issue this misclassification bias might be, I'm going to talk a bit about what we know about prevalence of cannabis use in pregnancy. So at the moment, we actually don't know what the prevalence of prenatal cannabis use is in Canada. We have no real valid estimates of that at all. In international studies from settings where cannabis is legal, such as the Netherlands and some of the US states like California and Colorado, we have prevalence estimates that are coming in around 4% of pregnant women using cannabis. The Canadian studies, like the ones I was just mentioning, the prevalence comes out around 1.5%. So like I said, this is likely really underestimated for a number of reasons. And just to show what we could be facing really in terms of prevalence, a recent anonymous survey, which would not be as likely to have this response bias, from Hamilton, Ontario, estimated prevalence of cannabis use in pregnancy around 11%. And another US study that used urine toxicology estimated at around 8%. So these are big differences. And basically what that means is that in the studies that we are considering currently our best evidence about the safety and the harms, potential harms associated with prenatal cannabis use, between 50 and 90% of cannabis-exposed pregnancies might be misclassified as unexposed in those studies. That's a huge, huge magnitude of potential bias. The other problem with this misclassification or poor measurement is that not having a real accurate prevalence measure doesn't allow us to estimate the real public health or risk of disease burden that's coming from this. So it makes it really hard to gauge if we're allocating adequate resources, how important it is to funnel resources into education, prevention, or treatment. And so that's a real problem, given that substance use in pregnancy is already a very costly issue in Canada. So these consistent measurement issues that we were coming across in the literature with these studies led us to believe that we needed to do something better. There's a clear lack of good measurement in cannabis use in pregnancy. So we developed and validated an antenatal cannabis use measurement tool that addresses some of the limitations that previous studies were facing. And for this, we used a patient-oriented approach and a 6-step process that is sort of adapted from Norman and Striner's guide for creating measurement scales. And I highly recommend that as a resource if anyone is looking at developing or modifying measurement scales for research. It's a really great resource. So the steps in this research project were a preliminary environmental scan to determine whether we really needed a new tool or if there was something else out there that could work. We followed that up with qualitative interviews with pregnant cannabis users. We conducted some cognitive interviewing, then convergent and discriminant validation, and internal consistency testing, and then finally reliability testing. And I'll go into the details of all of these as I move through. So as I mentioned, the first step we took was to do an environmental scan to see what measurement options might already be out there. We used literature searches for published material on cannabis use in pregnancy measurement. We explored what surveillance and population-based measures might be being used in jurisdictions, especially those where cannabis has been legal for a longer period of time than Canada, such as California and the Netherlands. And what we came up with, or what we found, is there's basically currently, there are about three sort of categories of options out there: biological testing, substance use disorder screening tools, and non-standardized survey questions. And an example of that would be what you'd see on the Stats Canada questions that go out to the general public. We had also determined that a good tool would need to measure at minimum whether or not someone's using it in pregnancy, how frequently they're using, and how much they use, and the timing of exposure in pregnancy. And we also are interested in what modes of consumption people are using, because as I mentioned before, we have no idea whether there is a differential risk associated with these different in consumption methods. There's also evidence that pregnant women perceive the safety of these different consumption methods differently. So many people consider smoking cannabis dangerous in pregnancy, whereas edibles or topical products may not be considered dangerous. So biological tests, there are obviously biological tests available for detecting cannabis that use urine, blood, or saliva samples. And even though we might think of biological testing as sort of a gold standard measure for a substance exposure, it is, there's no response bias in a biological test. But the biggest problem with these is that the best ones, the ones that are most accurate, only detect cannabis in the system for a short period of time, especially in people who don't use it regularly. So about 1 to 6 days for light users, cannabis could be detected in the bloodstream or other biological samples. And even in higher frequency cannabis users, heavier users, it's only about 7 to 30 days that cannabis could be detected in these specimens. So when you think about pregnancy, which is on average somewhere around 40 weeks, these tests are going to be of limited utility unless you can administer them multiple times throughout pregnancy. And that's problematic for research because these are invasive to collect. They can also be stigmatizing to pregnant women to collect, and that could cause a pretty substantial selection bias if we have people avoiding participating in research because they don't want blood testing or biological testing that would reveal substance use. The best tests, of course, are also more expensive. So it just makes this option really infeasible for long-term prospective research on prenatal cannabis exposure, especially when we consider that an adequately powered cohort study looking at perinatal and child development outcomes, for example, would require thousands of participants. So we kind of ruled out biological testing as the way to go. Next, we have substance use disorder screening tools. And I originally thought that this might be a source of measurement that we might find useful for research, but really what we found is that they're not well suited to what we need to measure. The biggest problem is that these screening tools are developed to measure something else. They aim to detect a pathological substance use disorder rather than to measure patterns of consumption or exposure of particular substances throughout pregnancy. So even though substance use disorder is a condition we're clinically interested in pregnancy, having a substance use disorder doesn't mean that you've been exposed to cannabis, and many people who have cannabis exposures don't have a substance use disorder, so they would be missed if we were using this type of screening tool to measure. survey questions that we came across are generally oriented to the general population and often don't apply to pregnancy for several reasons. The main one being that they don't capture that full pregnancy window. So we run into the same problem as we would with biological testing. Most of the questions ask about past week use or past month use. They largely don't have good measurement of dose, and the wording and the options for expressing or selecting your patterns of use seem to be incongruent with what a pregnant woman might be doing versus a non-pregnant person in the general population. We also noticed that there was no measurement of secondhand smoke or vapor exposure on these tools. And that was something we were interested in looking at because there is some evidence that the maternal partner's cannabis use seems to be associated with some perinatal outcomes. So we're wondering if secondhand exposure might be the vehicle for that. So it was clear to us at this point that we needed to try and develop a new tool to meet all the needs that we have in research to make sure that we can start generating some better evidence. So to do this study, we moved on to step 2 and through 6. So for these steps, we used targeted advertising on Facebook and Instagram to recruit women in reproductive age range, residing in Alberta, who had interests or page likes or memberships in things related to cannabis, and also pregnancy and parenting. We did a second wave of recruitment through AHS. Their data services allowed us to identify women who received pregnancy-related care in the previous 6 months, and then we had a recruitment letter sent out to them. We generally had a really, really positive response to this recruitment advertising. That's a picture of one of our Facebook ads that's up there. It generated a huge response. We actually had to shut down recruitment early because we had so many people inquiring. We were over 200 people in less than 2 weeks with this. And for those of you who do prospective research recruitment, you'll know that that's usually the challenge, is to find enough people. So we were really pleased to see this, and I think it bodes well for future studies dealing with this topic. So we conducted semi-structured individual in-depth interviews with 10 pregnant women who were cannabis users, either currently using in pregnancy or had used regularly up to pregnancy and decided to abstain. And our interviews really explored the thoughts, opinions, and experiences of these women with cannabis in general, as well as their thoughts and opinions and use during pregnancy. And we paid particular attention to the terminology that they used, how they expressed their beliefs about cannabis, their healthcare experiences, and their modes and patterns of use. And what we were really interested in picking out from these in our thematic analysis were bias triggers, or things that might inform us about why people tend to underreport, and what we might be able to do to ask those questions in a way that would minimize that underreporting. Interviews were recorded and transcribed verbatim. And then we conducted an emergent thematic analysis using a saliency approach, which basically means we allowed themes to come out of the stories that the women were telling us. We weren't going in prescriptively and looking for specific things, although there were domains of measurement that we were interested in picking out. We reached saturation after 10 interviews, which means that we weren't seeing any new themes coming out after that point. And we triangulated our data with an qualitative analysis of the comments that we received on our social media advertising on Facebook. So people can publicly comment on those ads, and we found a high degree of congruence between what the public comments were saying and what women on our survey, in our interviews were telling us. So 4 themes emerged from our qualitative interviews. The first was it's natural, so it's safe. And within this, there was a view that was expressed very pervasively that cannabis is not considered a drug, it's medicine. And it was important to women to acknowledge it as medicine rather than as a drug, which may be tied to stigma. It was largely viewed as safer than smoking and tobacco, drinking, or even prescription and non-prescription medications like diclectin, which is a commonly prescribed medication for morning sickness, and even Tylenol. There was a second theme that came through of distrust of the healthcare system and distrust of anyone who is not educated. And educated was sort of a term that was used specifically by this group, and I'll come back to this in a minute. The third theme was a perceived medical benefit. Almost all women talk about using cannabis not recreationally during pregnancy, but to treat some sort of medical condition. Although when we assessed what medical conditions they were taking the cannabis for or using it for, many of them wouldn't really qualify as medical conditions. So, you know, if you get stressed out or to relax you and so that you can be a better mother to your older children, things like that. But there were definitely an overwhelming number of respondents that talked about using it to treat morning sickness, and it's perceived as very effective for that. And the fourth theme was stigma. This is a pervasive one, which is tightly tied to decision-making about who you're going to discuss your cannabis use or whether you'll divulge use to a certain party. So on the screen here, you'll see these are some of the direct quotes from the interviews from women that demonstrate how some of the themes were really helpful to us in informing aspects of the tool. So this is really the real value of patient-oriented research, I think. This really showcases, we maybe would never have known any of these subtleties if we hadn't approached the patient population to ask them how to do this the best way. So things like saying cannabis instead of marijuana. And this person says because they think of marijuana only as being the plant, but not including other things like edibles or CBD products. But many people also associated marijuana with sort of a street drug term or an illicit substance, whereas cannabis to them sounds more acceptable and medicinal. Other people told us that they changed their patterns of use in pregnancy. So many women reduce the amount that they're consuming per sitting, but they increase the frequency. So they're taking it 3 or 4 times, multiple times a day to treat morning sickness usually. So that was something important to us in terms of having the appropriate frequency response options on the survey. I don't know how many grams or milligrams I use every time. One woman says, what if you compare it to something like a pea-sized chunk or a peanut size or whatever, then you could figure out the grams. So this was a key suggestion for us because dose is really difficult to get at in a survey. Most people who use cannabis don't keep track of the grams or milligrams of dried product that they're using. And relative terminology like saying a large joint versus a small joint or those subjective terms can be very, very different from one person to the next. So for a heavy user, 1 gram per sitting might not be considered a large amount, but for someone else, it might be a huge amount. It might be something that they would typically consume in a week. So we struggled a lot with how to ask about dose, and this comparison to common objects or familiar things was really a key suggestion that came out of these interviews. And then the last quote sort of touches on being open to discussing their use with a researcher or a care provider if the person were educated about it. So this is coming back to what I mentioned in the themes. There was this idea that people who are educated are people who acknowledge that cannabis is a natural, safe, and an effective medication, not a drug, and that they don't judge anyone for its use. So there's a perception that those who start a conversation with highlighting the risks of cannabis use are immediately against it, and that they wouldn't be considered educated or as a safe sort of discussion partner for women who are using cannabis in pregnancy. So all it takes to overcome this, though, is for that person to acknowledge, so for the researcher or potential caregiver, for example, to acknowledge that, yes, some people use cannabis as medicinal and it is effective for some things. They do find that it works. This is really tricky for us in pregnancy-related assessment because we don't want to promote something as safe if we don't have the evidence that it is, or if we have evidence to the contrary that it's actually harmful. However, it did really highlight to us how important and how crucial it would be for this tool to have a preamble that creates a bit of a trust relationship between the respondent and the researchers. So that was one of the things that it informed. We also used a lot of the terminology and feedback from these women to make sure that we avoided language and things that triggered that bias of not wanting to disclose. The interviews informed 5 specific wording choices as well. So saying consume versus used. Use is associated with drug use and addiction and can turn people off from disclosing. Medicinal versus medical was a preference. Calling it medication versus a drug, although any references to medication versus drug were removed by the end. The interview themes highlighted 6 preferred response options. We determined how to structure some items based on what women told us, and it, as I said, informed the dosage wording and the applicable ranges that would be relevant to women based on their patterns of use. So step 3 was cognitive interviewing. So because there isn't really a gold standard or a true measure of cannabis use in pregnancy, we had to get creative with how we were going to validate this tool. So one of the things that we did is this cognitive interviewing. So there are 5 stages of cognition that a person goes through that are required to accurately self-report behavior on a questionnaire. And each one of those processes or stages of cognition is susceptible to bias. So 1 is understanding the question, 2 is recalling relevant behavior, inference and estimation is 3, 4 is mapping answers onto response options, and 5 is answer editing. So what we did is an intensive cognitive interview process with 15 additional people. And essentially what it is an interviewer going through asking structured questions about how the person is processing at each of these 5 levels as they actually go through and answer each of the questions. So it's a very long, very intensive process. But we did this with these 15 pregnant cannabis consumers that hadn't been involved in the first interviews. And the feedback that they gave us and that we got from this process was used to refine the wording, the structure, the response options, and item inclusion on the tool. So it ultimately led to 15 different iterations of the tool. And once we had people going through it that weren't suggesting major changes, then we felt that we had our final tool to test out. So then we went on to the testing stages. So we then administered this refined tool to an additional sample of 140 pregnant cannabis users. And actually we had non-users in this group as well, but they were all pregnant. And we also included the 10 people who did the qualitative interviews in the beginning. We assessed convergent validity by looking at the statistical agreement between our tool, the responses on the tool, and the information that our participants provided in the in-depth interviews, which we think is a fairly decent representation of true patterns of use, because we had a very good trust relationship established with those women. And after an hour-long conversation, I think that it's pretty reliable information. So after that, we looked at discriminant validity. And so discriminant validity, as a reminder, convergent validity, first of all, is usually you're looking at how well your measure matches a gold standard measure. So you would look at how accurately your screening tool picks up a disorder like depression, for example. So a diagnostic interview would be the gold standard. But as I said, because we don't have that gold standard, we used our interviews as that gold standard for convergent validity. So with convergent validity, you want to see a high degree of agreement or correlation. And with discriminant validity, the purpose is to show that your tool is measuring something different than the ones that you know are measuring that outcome or that exposure poorly. So in our case, we validated this against 2 of the substance use disorder screening tools that we knew were validated in pregnancy, but by our judge were not adequate measures of cannabis exposure. The convergent validity testing was showed that the tool has very good to excellent convergent validity. The Cohen's kappas ranged from 0.73 to 1 for the 9 items on the scale. The lowest one there, the 0.73, corresponds with the trimester of use item. So we were expecting to see a change there, because there was quite a bit of time that elapsed between those interviews that we're using as validators and the second time that the people filled out the tool. And that was, we checked that the parts that didn't correspond were in the direction that we would expect, which is that on the later tool administration, people were reporting more trimesters of exposure than they were earlier in the pregnancy. So we don't, even though 0.73 isn't an awesome statistic, it's actually not unexpected on this, and it still doesn't detract from the convergent validity. The discriminant validity was also excellent. So again, a reminder that we want to see low correspondence when we're looking at discriminant validity. And the Cohen's kappas for this ranged from negative 0.27 to 0.15 for the 9 items. Step 5 was looking at internal consistency. And so unlike a screening tool for a single disorder, like depression, for example, internal consistency for a tool like that would show that the score that you give on any individual item on the scale would correspond to the overall score. Because tools like that are measuring a single construct, like depression symptoms, we would expect those correspondences. This tool is a little different, so it was a bit more difficult to figure out how to tackle this, because it measures multiple domains of behavior that really can vary by individual and that aren't really related to one another. However, we would still expect consistency between sort of no use versus any use on all of the applicable items. So for example, we wouldn't expect someone who reports never using cannabis in item 1 to then tell us that they've used 3 different forms of cannabis on item 6. So we conducted those, that internal consistency testing, and got really strong results with that as well. So an excellent internal consistency, Cronbach's alpha of 0.92. Step 6 and final step was reliability testing. So we then took this tool and re-administered it to all 150 participants 3 months after the initial answering to assess the test-retest reliability, or our approximation of it. Test-retest reliability is generally used when we're looking at a screening tool or an assessment that's administered by a caregiver or a researcher. But we thought that it would be important to see reliability in repeat measures in the same people with this tool. And this also turned out to be great. I was actually really impressed with this because there was some concern that because of some of the cognitive effects that might take place with cannabis, and actually even our users in the interviews mentioned this, that their recall, they didn't expect their recall of use to be very strong. But there was 0.92 weighted kappa, which is a really strong correspondence, and a tight confidence interval as well, 0.86 to 0.97. We are also exploring now the potential for using the tool postpartum, so immediately after delivery and in the early postpartum, to look at retrospective reporting through pregnancy. So the final tool, the Cannabis Exposure and Pregnancy Tool, or the CEPT as we call it, is comprised of that preamble plus 9 items. To our knowledge, it's the first validated measure of antenatal cannabis use intended for research purposes. And it addresses the limitations of the previously available measurement options, including those that were used in the bulk of our existing evidence. So the table here just shows you all of the things that the CEPT is measuring and where those gaps were in measurement with previous available options for measurement in prospective research. So future directions and sort of where we are with this right now. We're in the process of publishing. We've presented this material at conferences, and we hope to have a journal publication in the coming months. We're also planning some more validation studies using urine tests, and primarily among users that are reporting heavy use. And we just have to get that up and running. We've got ethics in place for that, and it's planned. We have eager participants. We're also using the CEPT now in a large anonymous survey that will be administered at delivery to women at select hospitals in Alberta in a population-based sample that was part of another trial, an unrelated trial. But we know it's representative because it was a cluster randomized trial. And that primary outcome for that is to get an estimate of prevalence. And we're hoping that the combination of this tool and the anonymity of the survey will give us a more valid measure of that than we have from other sources. We're hoping for around 6,000 responses on that survey. The tool is also planned for use in 2 large prospective cohort studies that are coming up. One that's already funded and sort of in development that looks at perinatal outcomes. Although cannabis is not the primary exposure, it will still be really interesting to see how the tool performs. And then another that is, we're hoping to have funding in place in the spring to begin that will look at perinatal health outcomes as well as child development and cognition up to age 3. So I really hope that this tool is going to provide the means to us as researchers to improve the quality of measurement of antenatal cannabis exposure and thereby improve the evidence base that we have to inform policy interventions, education, and practice. It really does improve the ability to evaluate different domains of exposure, the timing of exposure, the frequency and the dose, the mode of cannabis on maternal and infant health outcomes, these are things that we've never been able to study before. So I think it really has the potential to substantially improve the quality of prospective research evidence. And I might be a little biased because I'm invested in it, but I do think that it's a positive contribution